Hi, my name's Evan, and this is the barium enema trigger. So, looking on the computer, we just had a barium enema pop up on here, and I'm gonna go into the room, make sure everything's ready. And the room's all set up. We got our barium bag with the tube and the contrast in it, and we have our KY jelly here to help the insertion. And now I'm going to go and alright, now I've got the requisition, and I am double checking that it's the same order, which it is. And now I'm going to go. Hello, Priscilla?
Yes, hi.
Hi, my name's Evan from radiology. I'm here for your procedure. Can you verify your date of birth for me?
It is 8/1/84.
Okay, thank you. And what kind of symptoms are you having today?
I've been constipated for the past few days.
Constipated?
Yeah.
Okay. And did you do the prep that we requested for it from you?
Yes, I did.
You did? Alright, we'll come right this way and we'll have you change into a gown.
Okay.
So we now have the patient on the bed, ready for the procedure. I explained the procedure to the patient, and for this procedure we will be using a high density barium of a lower temperature of about 41 degrees Fahrenheit. And the patient is properly covered and shielded on the table and is in the Sims position. And I will have my supplies up here, my barium bag and KY jelly, and I'll make sure to not have the barium bag exceed 24 inches above the table in the patient. And I will also, when inserting the tip, make sure the tip does not go past 3.5 to 4 inches. And then after I insert, the doctor will inflate the balloon of the tip to make sure the tip does not escape the rectum. Alright, I will now be inserting the tip for the procedure. I have my barium bag filled with my contrast, shaking it up, make sure everything's flowing in there. It's not stuck or solid or anything like that. And I have my tip and my KY jelly. I will lubricate the tip and then come over to my patient and have him in the Sims position, and I will gently insert the tip into the anus, making sure I'm in the right hole, and slowly insert till about not exceeding 3.5 to 4 inches. Alright, now the procedure is finished and the hose is clamped off, and the radiologist requested 8 overheads, which I will now demonstrate for you. Okay, so I now have the patient on the table, dressed in the gown, and we'll be performing a scalp TriggA BE before the procedure. I'm going to insert my film, portrait, and we'll line up to with my bucky. Okay. And now I will palpate for the iliac crest, because that is where you want the central ray of the IR. And I have it's the mid-sagittal plane with the iliac crest, which I have, and it's 14/17. And the KDP I would use for this would be ballpark 75 KDP and 40 mass. And the patient is shielded below. If possible, it's harder on females, but on males you can shield below the collimated light. So the procedure is now done, and radiologist requested overheads, and I'll be now performing. The barium hose is clamped off, and we now have the patient in a prone position, and we'll basically be taking a KU BE. And for all the overheads, the ballpark technique will be between 90 and 100 kbp and 40 to 50 mass, give or take. So I now have my film in the bucky portrait, and we'll be lining up my tube with my bucky. There we go. And I have 40 inches on the tube, and we'll be palpating for the patient's iliac crest. That is what you want the central ray. We have iliac crest, perpendicular with the IR, and at the mid-sagittal plane. So there we go. And I will go ahead and take the image for that. I'm placing a marker on the correct side of the film, and already have everything set up, and will now shoot. Next overhead I will take is the PA axial, and it's done on a 14 by 14. Insert it into the bucky. Place my marker on the correct side, and then this has a 30 to 40 degree cauted angulation. So I will set my tube up with that. Now that my tube is angled, I will line it up with the bucky. There it is. Okay. And now I'm going to have it lined up with the mid-plane of the patient and on the level of the as-is. So I will now palpate for the as-is. There it is. Alright. Everything is all set. I will now take the picture. Okay, I will now be performing the REO projection, and I will have the patient get up, rotate onto their right partially with your left forearm supporting and your left knee supporting it. Not quite so much, a little bit less than that. Here we go. I want them at about a 35 to 40 degree angulation. And my tube and my bucky are already aligned. I have my film in there with my marker. And this I am lining up with the iliac crest, and we are looking for the hepatic flexure. So I have that all lined up, and I will be taking my picture. Okay, this is now the right lateral projection, and we use a 10 by 12. Place this in here. Have my right marker placed in the correct positioning, and line up my tube with my bucky. There we go. And I have the patient in the lateral position on their right side, and I will be lining it up with the as-is. I'm going to palpate for the as-is. Line it up there, make sure they are rotated. I'm now performing the right decubitus projection, and I'm putting my marker up in the top corner, and I'm going to place this film holder behind the patient, and the patient is on an elevated pad, so we do not get any clip off of the anatomy. And I have my tube over here perpendicular to the film, and I have it lined up. Central ray is on the iliac crest and with the mid-sagittal plane. And now I'll take my picture. This is now the LAO projection. And I will have the patient rotate up onto their left side and rest on, and then all the way, and rest on their left forearm, and then bend their left or the right knee, right forearm and right knee to make a 35 to 45 degree angulation. And I already have my tube, my bucky lined up with my marker on there. And I will now set up for, you want the central ray at the iliac crest, and you want to go 1 to 2 inches lateral of the midline of the patient. Right there is good. And I will now take my picture. This is now the left lateral decubitus projection. And I have my film holder with my film with a grid and my marker up in the top left and the bottom left. And I will be placing this behind the patient. And the patient is on an elevated path to get no anatomy cut off. And come over here to my tube and line it up with the film, perpendicular, and I'll feel for the patient's iliac crest as a central ray, and collimate down to the grid, and I will now take my picture. We are now on the post-evac picture, and the patient already went to the bathroom and is now back. We're going to take an image and see how everything looks in there. I'm going to use a 14 by 17 portrait, place it in there, line it up with my bucky, just like that. I'll put my marker on the correct side. And now, patient's hands on their side. I will be feeling for the iliac crest and have the central ray be there, perpendicular with the mid-sagittal plane. And then we'll take my image. And that completes the barium enema series. I will now be evaluating the following images I took. Here we have an AP projection, which I decided to do with the PA. You want the IR perpendicular to the midline of the body at the iliac crest, and you use a 14 by 17 film. The criteria you want to see in this film is the entire colon with the splenic flexure and the rectum, and you want to make sure the vertebral column is centered in the middle of the film. Here I have the PA axial projection. Patient in the prone position, preferred to use a 10 by 12 lengthwise. You have the central ray 30 to 40 degrees cauted to enter the midline of the body at the level of the ases. In this, it best shows the rectosigmoid area of the colon. This is the RAO position, PA oblique projection. The patient is in the prone position. You use a 14 by 17 inch film. The central ray is perpendicular to the IR and entering approximately 1 to 2 inches lateral to the midline of the body on the elevated side of the iliac crest. In this position best shows the right colic flexure, the ascending portion of the colon, and the sigmoid portion of the colon. Here we have the lateral projection, which I chose to place my patient on their right side. The central ray is perpendicular to the IR and enters the midcoronal plane at the level of the ases. You use a 10 by 12 lengthwise for this projection. The structure shown on this is the rectum and the distal sigmoid portion of the colon. Here we have the decubitus projection, or position. I chose to do both of mine AP. You want to use a 14 by 17 film and include the entire colon. On the right decubitus, you will have the ascending and hepatic flexure filled with barium, and air in the descending and splenic flexure. And on the left colon, or the left decubitus, you will have the descending and hepatic flexure, or splenic flexure filled with barium, and the ascending and hepatic flexure filled with air. This is the PA oblique projection, LAO position. The film size is 14 by 17 inches. The central ray is perpendicular to the IR and entering 1 to 2 inches lateral to the midline of the body on the elevated side of the level of the iliac crest. The structure shown of the left colic flexure and descending portion of the colon. You want to see the entire colon, the left colic flexure less superimposed or often compared with the PA projection, and you want to see the descending colon. Now this is the post-evac. This is the last film of the series. You can do it in an AP projection. Use a 14 by 17 inch film lengthwise. Place the patient in supine position. Have your central ray perpendicular to the IR and enter the level of the midline of the body at the level of the iliac crest. And you want the entire colon included with the splenic flexure in the rectum and the vertebral column centered so that the ascending colon and descending colon are completely included. And that wraps up my trigger. Now this is the post-evac. This is the last film of the series. You can do it in an AP projection. Use a 14 by 17 inch film lengthwise. Place the patient in supine position. Have your central ray perpendicular to the IR and enter the level of the midline of the body at the level of the iliac crest. And you want the entire colon included with the splenic flexure in the rectum and the vertebral column centered so that the ascending colon and descending colon are completely included. And that wraps up my trigger.